So good afternoon. My name is Achyuta V Nori, and my connection with Scotland is that my first consultant job was here in Edinburgh. And quite a lot of what I will be talking about is kind of ideas that started out here. Particularly, I think I need to give a shout out to Ellie Caldwell, who's the psychologist here at the Chalmers Centre, and we were kind of talking about care plans, which is kind of where I will be going with this. So this is a very, very different kind of beast from what Jane has been talking about, and very unusually for me, I'm not going to talk about research or data. I'm going to talk about how we can do this in clinical practice, and I have no disclaimer, so conflicts of interest. So I'm just going to talk a little bit about the changing landscape of HIV care over time, and this is kind of as important because it kind of puts into perspective what the experience of people who are seeking care for HIV had to go through at different times, but also about people giving HIV care, what their kind of priorities are and how they had to adapt, because as you know, HIV care has changed quite a lot over time and very rapidly compared to other medical specialties. And then kind of looking at HIV as part of a multimorbidity care. And then I'm going to do a little plug of what we're doing in my local centre, which is called the Living Well Clinic, and then talk a little bit about other things that we can think about for the future. So if you kind of look, this is a infographic looking at all the HIV drugs that have been approved by the FDA over time. If you kind of think about how things have evolved, before there was any treatment that was available, there wasn't anything much we could do. So if you're looking at pre-1985, it was basically more about comfort care and palliative. And then with the advent of zidovudine and then all the other drugs that started, you started the next step we talked about for the next 10 years is more about survival. So you're talking about treatment which can prolong life. Quality of life was not even in the equation. We just want survival was the best that we could achieve. The next step which we came through with highly active antiretroviral therapy was control. So you're for the first time able to achieve undetectable viral loads, and that's where kind of people were kind of so focused on those numbers that, you know, sometimes irritates some people, kind of going, why are you so obsessed with that? Because we've kind of gone through that process where we're kind of talking about all that we can do is we can achieve control, which then would give better outcomes. But we had limited options for that. So you had lots of times when we used to talk about things like salvage therapy, where we were kind of trying to do is that we don't have any treatment options. And then came the next stage where you had your very effective, very potent, but durable drugs which don't easily get resistance, which means that not only is it easy to make people undetectable, but keep them that way. And there are options. So it's not just that you have one or two options. It made it a lot easier. So we kind of need to change as healthcare providers, change how we think about it. As Jane said, it's beyond undetectable to kind of look at how we manage patients. It's not just about, is your viral load okay, is your CD4 counter okay, goodbye, but actually look at make it into person-related, but also to take into effect that depending on where in this cascade of time people had been diagnosed with HIV and what their experience of receiving care was, the relationship with it is quite different. So if you look at people who are diagnosed in the 80s and the 90s, it's quite a traumatic journey. The drugs were horrible, the regimens were number of pills, the side effects were lousy, and it was easy to become resistant to. So their experience of HIV care is very different from somebody who's diagnosed in the 2000s who thinks it's no big deal. So I think it's important to kind of look at what those lived experiences are, and where healthcare providers are not particularly good at that. And I think that it's kind of that's where a shift needs to come. Jane talked a little bit about the 1990 targets, and these were kind of introduced in 2013 by UNAIDS with the idea that if by 2020, 90% of people who are living with HIV are diagnosed, and 90% of those who are diagnosed are on treatment, and 90% of the people who are on treatment are undetectable, by 2030, we will be eliminating new transmissions and stop the epidemic. And England achieved these targets in 2018, at least it was reported then. So the next thing is to talk about the fourth 90, the good health-related quality of life. And as Jane said, I don't look at this as the part of the casket down there. It kind of encompasses everything. So I like this infographic because it basically says that, quality of life is at every step, and we need to kind of think about it, which then brings me on to the main meat of what I'm going to talk about, is multimorbidity. So right about the time when I joined here in Edinburgh, the NICE, which is the National Institute of, they keep changing their name, Health and Social Care Excellence, had published a guideline on multimorbidity. Now, this is kind of more looking at care of the elderly and looking at clinical and assessment and management of people with what they call multimorbidity, which is defined as somebody who's got 2 or more long-standing physical problems, or 1 or more long-standing physical condition and 1 or more mental health conditions. So if you kind of look at how HIV care fits into it, you already have 1 long-term physical condition, which is HIV. So if you have anything else going on, it's down the it is eligible for the multimorbidity care plan. And what came out the year afterwards is that NICE published their quality statements, which are basically the 4 quality statements, is that they looking at identification of multimorbidity, assessing values, priorities, and goals. So this is clinicians and patients working together to look at what people's priorities are. So this is looking at a different way of looking at health, because it's not just about what I as a clinician, what things you should have as a patient, but it's actually working together to look at these are the problems, where are your priorities, what do you care about, and what do I care about, and then kind of getting together to come up with a care plan, and then coordinating that care so that kind of go across multiple agencies. So as you were talking about being pinged across from your HIV clinic to the GP, it's actually kind of how do we get to kind of have better joined up care. And the most important thing, which is kind of a bugbear for me, is it's basically reviewing medications and other treatments. What the traditional model of care is, you'll have your HIV physician kind of looking at the HIV medicines, and if you're kind of having other medical problems like diabetes, somebody else is looking at that, and then you have patients who are in what's called polypharmacy, so multiple tablets and struggling with that, and kind of looking at what priorities can you have, and everybody looking at things in isolation saying, well, my medicines can't be changed, so somebody else has to change it. And the person who's losing out is actually the person who's in the middle of that, who is living that. And it's kind of how do you accommodate all of that. The guideline is very good because I love flowcharts, and it basically kind of goes through kind of telling you what you need to do, and most of this sounds like common sense, but it's basically kind of saying how do you kind of identify people who may benefit from a care that takes into account multimorbidity. Now, I've kind of deviated a little bit from brief because your age actually doesn't have anything particularly to do with this, because you can have multimorbidity at any stage in life. And some people, like probably can name drop Matthew Hodson because he tweets about his amazing quality of life all the time. He probably has got a much better quality of life than me, and is definitely fitter and healthier than me, would probably kind of not fit into that. From what we know from Twitter. But somebody else who's kind of got other problems, and particularly an issue with people who struggle to fit in. So you're kind of talking about people who are marginalized. So you kind of look at ethnic minority, migrants of any ethnicity, people who who are trans and LGBT, basically have other issues which impacts on their how they cope with their care. And it's important to kind of factor all of that. Addressing frailty is kind of more of a false assessment, which is kind of not what we particularly want to do. That's kind of, if you're 80 plus, it's probably that, which is what this guideline is actually aimed at. But I've just kind of thought that this is something that we can use for managing HIV, and it would be a very good approach. So basically what that assessment would include is assessing not just their medical needs, but also their social care needs, and then looking at, what are the caring responsibilities, who's actually kind of, do they have people who are supporting them, and also getting adequate training for people who are providing both their health and social care to kind of work together, because it's rather than kind of just focusing on one thing, is to look at the whole picture. And the other thing is medicines optimization, and this is the whole kind of thing, but if you look at that, it's basically kind of looking at what prescribed medications are there, and it's having a system by which somebody takes responsibility for making sure that the medication that they're on is appropriate, that they feel empowered to manage them taking the medicines. So we identify if they need any support, and the idea is that you kind of empower people to self-manage, and we are there to support you. And if they were to transfer their care, then they have a comprehensive communication of that care package goes across to their new care provider, so that people don't have to start from scratch. So this is the guideline. So Ellie and I were kind of talking about the HIV care plan. So she was basically very, very keen that we basically documented for all our patients about their psychological needs. And when I joined here, I was kind of thinking, actually, we kind of need to also know about their social care needs, their medical needs. And so we thought that we could kind of make this a bit more holistic and talk about physical health. We need to have a comprehensive list that says all the medical problems and who is looking after what and what medication they're on. We need to know about their mental health, particularly focusing things on mood, sleep, appetite, memory, and cognition, which Chris would be talking about more in detail. Social, about housing, job, support. Particularly what is important out here is quite a lot of the narratives that came out in clinic, both where I work right now at Cousins and Thomas's and when I was working in the Lothians, was about isolation. The people it's probably London is a much larger kind of, you have HIV communities, which you don't really have here. And particularly if you look at the ethnic minority populations in Edinburgh, who basically all used to come and tell me how they were the only one in Scotland with this. And you're just like, no, but you don't actually get to talk to somebody because it's very, very difficult because of the kind of it's kind of looking at incorporating how people deal with stigma, which basically is, again, it's a lived experience of what they have experienced so far of stigma and which kind of then kind of informs their behaviors and what they fear and what decisions they make. So my kind of one line on stigma is that I think that stigma is kind of driven by shame, and nobody has ever kind of achieved anything good out of shame. The only thing that you get is unhealthy coping strategies. So it's something that we really need to be better at dealing with. It's easier to say than to do. And again, this is where there needs to be a lot more social qualitative research. And it's kind of it's not just it's something we need to do at a general population, because the source of all the stigma is not the people living with HIV, it's everybody else around them and the communities they live in. So we need to incorporate that into research. And then what's important is also about sexual well-being. So in this, we've kind of got for women things about their contraception, menopause, to kind of look at that, because quite a lot of, when you talk to women and the experiences of menopause, they kind of find that nobody ever asks them about it. And they feel like it's inevitable or it's natural and you have to live with it. And it's a question of trying to see what is it that you want and what can we achieve. So some people don't want to take hormones, and it's kind of looking at, what are those issues and looking at what is the best support that you can get rather than kind of go, this is your lot in life. I talk a lot about sexual health because what's happening in England is that because we're devolved, you basically have different funding streams. Sexual health and HIV care have been completely separated and torn apart, which basically wasn't the case when I was here. And so you're much luckier out here than we are. But how do we kind of make sure that, because a lot of that kind of drives the poor quality of life, because it's about kind of, are you having sex that feels safe? Is that kind of satisfying? Do you kind of feel are you at risk of infections? As you kind of, there's a lot of in the press about increasing antimicrobial resistance and increasing prevalence of all infections. So is that, who's looking after that? So actually having a care plan is something that would be useful, and talk about that in future considerations in a second. So I thought I'd just give you a case study to give an example of what I mean. So this is a person who I look after who was diagnosed with HIV in 2001, and he was at a different center and things were going slimmingly well until 2016 when he disengaged from care because of whatever reason, and stopped his antiretrovirals. He presents a year later to us, and he wanted to re-engage with care, but at this point he was short of breath for a few months, so we examined him and we found that he had a few new medical problems. He was found to have a heart murmur and lung crackles, and it turned out all of this was because he had syphilis in the heart, and which is how he ended up with me. Everybody with weird syphilis comes to me. So he had a aortic root dilatation and loss of heart function. So now he needs a cardiologist. So the syphilis has been treated, but this is permanent. And because of the reduced heart function, his lungs have kind of become, he's developed what's called pulmonary hypertension, which is why he was kind of getting short of breath and wheezy. He also had reduced kidney function. So he went from somebody with no problems to quite a lot of medical problems. We also incidentally found that he had this fungus called Cryptococcus in his blood, but not in his brain. We weren't sure what the significance of that was, but because his immunity was quite low, he was started on treatment for that. So he's on quite a lot of medications. So that was probably 2 meals a day. But also he needed to see quite a lot of people. So he needed to see a cardiologist who's based at St. Thomas's Hospital. And they need to see him because they physically have to do tests on him every 3 months. And they were also giving him quite toxic medication that needed drug levels and stuff. So that was quite important and not negotiable. For the pulmonary hypertension, he needed another 3-monthly visit, which was in Guy's Hospital. And then he needed to see me every 6 months, which was in again Guy's Hospital, but I work on a different day to this, a respiratory physician. His mood was surprisingly good, but actually it wasn't that surprising, and he couldn't cope with all of this, so he moved out of London to Suffolk and said that moving out of London made him very happy. It stressed me out, but didn't stress him out. For his care plan, his HIV was stable. We knew what he was on. There was nothing that he needed to physically see me for. So what we decided was that I would remotely manage his care. So he needed to see the respiratory physicians, that they had to see him and do stuff. The cardiologist needed to see him and do stuff. So it was like coming down from Suffolk, which was like about 30 miles out. It was quite a long way. So I said, fine, I'm going to talk to the physicians and we're going to work together. I'll make sure that you get your appropriate tests when you see these people. And when you come for your respiratory appointment, I'll make sure that your medicines are available. And this makes it sound like I'm very organized. I basically gave him my email address and said, contact me when you're coming so that I can get all this done, because otherwise this is going to go pear-shaped. If you had a care plan, if he had something, so this is something that works very well. But if you have a system in place, then it's something that I think would basically work a lot better. And there's a lot where we can kind of change the way we manage patients so that we can use our resources better for people who need more interventions and people who kind of don't need to see us so often, don't particularly want to see us either, can get on with their lives. So as we age, and this I mean the life course from birth to death, there are lots of things that we accumulate with time, things like we increase our risk of heart disease and stroke as we get older, musculoskeletal problems, so bone density reduces, people do get, as we get older, wear and tear, so you're more at risk of arthritis. And the other thing is that we kind of memory starts failing. This kind of things that we kind of need to look at and see, is there anything we can do? Then you also have lifestyle related issues, so things like obesity, cholesterol related issues, and metabolic syndromes, so things like fatty liver, type 2 diabetes, which are lifestyle related things. And then as we go through time, the more time we spend on the planet, the more medical problems we get, which is kind of one of the sad bits of being alive. And socially, kind of things is that, particularly with living with HIV, there's kind of a lot of the experiences with stigma, which basically would kind of result in isolation. So I think all the studies that Jane was kind of talking about, where you have better quality of life if you have a partner. It's kind of, if you don't have anybody around you, that gets lonely, and then things get hard. So at Guy's and St. Thomas's, we are starting next month a Living Well clinic. So this is not age restricted. This is a pilot service that we are doing, which is funded by Gilead and MSD for 2 years, we've set it up as a mixed methods observational cohort study, which basically means that we're going to get people who are eligible for this in, and we're going to monitor them for a 2-year period. And this is a person-centered multidisciplinary rehabilitation program for people who have got lifestyle-related issues. So we're looking more at the metabolic syndrome end of things. And it's so the reason we don't have psychology in here, because the way mental health works in England makes it very difficult to work together, because it depends on where you live, what you get. So let's not go there. So this is done with a physiotherapist, a specialist dietitian, and a HIV clinician. And they're doing a lot of patient-reported outcomes scores at the initial visit and every 3 months. So the first one is the HIV patient-reported outcome measures, which are presented. So it's kind of a thing which is commissioned by the British HIV Association. It's a tool that's got about 30 questions in the questionnaire. The patient activation measures looks at people's activity scores, and that's about 17, I think. Then there's a goal attainment scaling, which looks at all these measures and looks at what your motivation for each of these aspects is. And then there's a quality of life score, which is the EQ5D. So it's death by questionnaire that they're going to get first. And then they basically have tailored interventions, which could be regular dietitian consultations by different methods, depending on what works for them, which could be either face-to-face in clinic, virtually, or by email or Skype, regular physiotherapist consultations, as well as they have joint sessions with the two. But quite a lot of this is to basically, in the first 10 months, is to get people through their activity scores and get them supported to become independently more active. So they have fitness trackers, and then the HIV physician will be doing what I talked about, getting that care plan in and making sure that the medications are optimized and all their care is coordinated. And there are group activities which kind of increases education, so people feel more empowered to take control of their health. We also have included smoking cessation therapy for those that need it in this. We're going to be, this is to set it up as a qualitative research study. So we have a social scientist who's going to do in-depth interviews and focus groups with the people who are participating in this. So we're hoping to get pretty in-depth data about this, but we'll also measure all the medical things that we love to measure. So a whole lot of tests, and you can tell that I work in London. We have access to DEXA scans. And the idea is that at 24 months, we kind of see if this is a feasible intervention. And obviously, at 12 months, we're going to tailor it based upon, because I don't think it's feasible to kind of ask somebody to fill in about 50 questions every time they come in. They're probably going to hate us. So I think that one of the things that we kind of need to think about is to develop a HIV multimorbidity care plan, kind of, so that we have a standard system which basically helps HIV services to have a more holistic, coordinated care for patients, and also that somebody has an overview. The biggest issue we have with HIV is that still there's a fear amongst medical professionals about HIV medication. The moment somebody has HIV or their HIV medication, they'll be like, oh, you can't do anything about that, I don't know, go and see your HIV physicians. So for the moment, probably that medicines reconciliation and review should be in the HIV clinics, and probably that's something we need to work on. And the other thing is about planning care through the life course with patients. And this has come out of conversations I've had with some of my patients, or 2 of them, who are in their 70s, who then asked me a question which kind of I found quite distressing at that point, where they said, when can I stop my HIV medication? And I went, no, you can't do that. And they went, why? So you say that HIV therapy is going to prolong my life. So when I'm by 10 years, when I'm 90, what are you hoping to achieve? It's like, I've never actually thought about that. And I've asked all my colleagues, and they said they've never thought about that, and they had exactly the same reaction as me. But I think that that's a conversation we need to start having, because it needs to be about quality of life. And we need to shift the focus onto that. And undetectable might be great at sometimes, but if you're at a different stage in your life, maybe that's not the most important thing. That's something to think about. And that's me.
Dr. Nori, thank you very much. I found a highly informative presentation, and I found the case study particularly helpful in developing my understanding of the reality of co- and multimorbidities, a term that is, bandied about in political discourse and discussing health, but can sometimes be a bit abstract and can fail to properly consider the actual lived experience of those with comorbidities. I also found the discussion, your final remarks, for someone perhaps when I reach 90, what then? And the question of life expectancy, healthy life expectancy and well-being chimes with much of the realistic medicine agenda that we have in Scotland, as promoted by our CMO. I think we've maybe got a couple of minutes if anyone would like to ask a question or make a comment.
Hi. Just one comment, so I've put my glasses on. Oh yeah, in your Living Well clinic, what's the proportion, percentage of people attending that clinic out of the total number of people that, with HIV attending that clinic? How many people do you think need to go through that?
Oh, this is a pilot, so we're going to have 30 people going through this.
Right, fine.
And it's going to be patient consented.
Okay.
So we're hoping it'll be, the eligible population is probably much higher than that.
Yeah.
They may not want to do it.
Yeah, of
Quite
course.
a lot of the things we talk about, nobody wants to see a dietitian. So as Nicoletta said, the advice you give is not what people kind of want to follow. It's also kind of looking at people's social circumstances. It may not be on your priorities. If people have to kind of work 2 jobs, they have caring responsibilities, kind of going healthy eating is quite difficult to coordinate in that. So the thing is that you kind of need to look at the whole kind of picture. And it's that readiness for change. So this is kind of a pilot to see what the intensity of that is going to be, what the acceptability of it is going to be, which is why we have this structure where we're going to be re-evaluating it and going to phase 2, which is going to be, I don't feel that, I've looked at the questionnaires and I've gone through the prompts, and halfway through it is like, how much more is there? Because it keeps going on. We have a tablet in clinic where people can kind of fill it in. Yeah. So it's kind of looking at, you need to have something that's workable, realistic, to kind of say how we can measure it, because you need to kind of show that whatever you're doing is going to be of value. How would you define that value is the other thing we're hoping will come out of the in-depth interviews, because that's where lived experiences come out. Okay. But initially it's just 30 patients. 30 Our cohort patients, is 4,000 patients, so less than 1%. Okay.
So I remember a couple of years ago at BIVA conference, one of our esteemed clinicians said something like, let's face it, guys, and she was talking to other clinicians at the time, we're not very good at all the fluffy bits. And I think they were referring to really psychosocial health. But, this is a medical model still. Maybe it's a lot of our care medical model. It's only more in the more recent years. We've got the psychosocial and all the other elements, social care, etc., coming into care for HIV. How are clinicians really going to adapt, and how do you think, your thoughts on the, of course, how much more resource we're going to require for that community, requiring that kind of holistic package of care that's going to come in? Because alone, you talked about your case study saying, you organised this, that and the other. You couldn't do that for 150 patients.
No, I can't.
So do you have any thoughts on how we could manage that at the moment?
Yeah, I think that it's kind of being more smart. This is where you can, because the other thing which I did in my bio, the care redesign, it's looking at how do you redesign your services with the resources that you have, so that you can focus your interventions, because a lot of people don't need that much. Yeah. And some people do. It's kind of identifying those who do and then trying to put the thing, and it's basically having systems in place. So part of it is having this dialogue. It's kind of saying that it's not enough to just kind of go for undetectable, I don't care about anything. It's kind of looking at what your experience of taking those medications are. It's kind of saying, talking about other medical problems that people might have, not going, that's not my problem, go to your GP, go somewhere else, but have that kind of, you need to have a holistic view of the medical things. I think that sometimes where people have tried to kind of go into the psychosocial aspects and they've forgotten to do the medical aspects, and then you sit there and go, hang on a minute, who is looking at whether this is safe, is that this is appropriate, do you really need to be on this? So where sometimes people might be on drugs that they probably don't need, and it's driving a lot of side effects where people kind of are struggling to take the tablets of adherence has been an issue. The question is, ask why. Part of it is just getting people to kind of, ask questions with curiosity, listen with intelligence. So it's basically listening to people, understanding what they're saying, and then reacting to that. And that's what people look for. You kind of go to leadership courses and talk about this, but it's true of everything. And these consultations we need to have, that all you need to do is, this is kind of looking at somebody as a person. You're not a virus, you're a person. That's what we need to start looking after. And I think that's kind of, it's a change, because previously that was the obsession because you couldn't do it very well, but now we can. So the time for change has come. We need to have, this doesn't need resources, this needs a change in attitude. It's kind of having these discussions in forums like this, but including care providers, to kind of saying, get your act together. You need to change. This is a new change. It's always been changing. You've always been obsessed about this, but the world has changed. We need to. Yeah.
Thank you very much, Dr. Nori.